So 2 weeks ago, I stepped away from family, patients, team, and dove headfirst into 4 days of pure estrogen, testosterone, progesterone evidence, and empowerment. Because every fall, hundreds of clinicians, scientists, and innovators, they all come together for the Annual Menopause Society Meeting. This time it was held in Orlando, Florida, and we had just a really great time meeting up with anybody. And all of those who care about women's health, this is exactly where the future gets written. Now, I'll be honest, as a founder, leaving like everything behind and taking that time off isn't easy at all. You know, the inbox keeps going, your email, the patient portal, the clinic, all the things. And if you're the only one running it, then nobody is being seen and you're still having to be the one to follow up on all of the questions. Then also being a mom, you have the mom guilt that you are not home. Is everything going to be done okay? Are the kids going to get to school? Are they going to be fed? Are the dogs going to be fed? But I did have the really great time of bringing my oldest daughter as a third-year medical student with me and her best friend, who's a physician assistant in family medicine, who they've been best friends since they've both been 4. And so they both traveled with me. And it was just a really great time to show them all the fun stuff, meet colleagues, mentors, and just really get some of this women's health under their belt. But we also know that is also what growth looks like, right? You have to invest in the learning that keeps us sharp, keeps us updated, keeps us connected, and also inspired to push the mission forward that we're on in women's health advocacy in particularly. So today I'm taking you inside the 2025 Annual Menopause Society Meeting. This was 4 days of data, connection, and a reminder that midlife medicine is the heartbeat of longevity. All right, everyone. So let's talk about day 1. And of course, I'm going to preface this with, these are my key takeaways. Someone else that was there may have had their own key takeaways or things that really resonated with them more. But for me, these were more of my key takeaways. So the brain, the biology, and the beginning of transition. Day 1 was all about the neuroendocrine transition and the real biology of perimenopause. It was really exciting because I really felt like perimenopause had a place, which is super, super exciting, especially for those of us that take care of perimenopausal women. So, the message was very clear that menopause is not a single moment. Obviously, the definition is 12 months and 1 day without a period. But really, we talk about that it's a brain-driven transition, years in the making. Some of those key takeaways we talked about where perimenopause begins long before the final menstrual period and is divided by fluctuating FSH, AMH, and estradiol levels. We talk about the antral follicular count, the AMH, which are useful indicators of ovarian reserve, but they're not diagnostic on their own. Mood changes and sleep in the late reproductive phase often stem from hormonal variability. And you hear me talking about that a lot, especially those of you that are my patients. I talk about this up and down and up and down. We talked a lot about depression and anxiety, which may increase during the late transition, should prompt screening. And holistic menopause care includes addressing metabolic, cognitive, and neurogenital changes alongside the vasomotor symptoms. I really liked that holistic care, that nuanced care, that every woman is different. The perimenopausal transition is a prime window for preventative care and patient education, which, this is empowering women to anticipate changes and protect their long-term health. We heard data about how fluctuating estrogen impacts the neurotransmitters, things like, serotonin and GABA, which I talk about this a lot. If you ever hear me talk, explaining all of that, it can explain why mood, sleep, anxiety often shift during this transition before cycles stop completely. The brain is the first organ to feel these hormonal changes. Again, defining perimenopause often begins earlier than expected. So that also was exciting. A lot of us talk about like the mid to late 30s. And it was so nice to see that being validated in the lectures, that most women or clinicians expect sometimes these women will be in their late 30s or early 40s, that women frequently report emotional, cognitive, and sleep symptoms before their changes in the menstrual cycle. And if you're taking care of these women clinically, you're seeing that. Many patients feel dismissed or invalidated when they raise early symptoms of perimenopause. Women are still being told that by clinicians that clinicians don't think perimenopause exists. It was, again, very validating, for us clinicians in practice who are hearing all of this. Clinicians should provide anticipatory guidance starting at least around age 35, helping women recognize the early signs. The menstrual cycle should be viewed as the vital sign, prompting cycle and symptom tracking. Super important. The more that you're tracking your symptoms and understanding your cycles, it just gives us so much more information. Make sure that clinicians are using clear communication and empathy to validate patients' experiences and correct misconceptions. This is big. And again, a modern approach to perimenopause must bridge biology, experience, and education to improve care quality. We talked about abnormal uterine bleeding. Of course, I'm going to go through this fast, you guys, because there's a lot of stuff here. So, it's common in perimenopause, but it's not always benign. So it's not always just perimenopause, right? So we need to make sure that they're not fibroids, adenomyosis. You need to make sure that you're talking with your GYN to see if you need an ultrasound or any other types of interventions. Okay. We talked about first-line treatments for this, hormonal therapy, things like IUDs, progestin, contraceptive hormonal pills as well, and that we need to distinguish normal physiology variation from pathological change. So then on to vasomotor symptoms, sleep, and mood. So key takeaways here. Most research focuses on symptom treatment, not symptom design or clustering, which sometimes can limit personalization, that mood and sleep are interlinked. So we understand that if you're not sleeping, your mood's going to be terrible. And if your mood's terrible and you're super anxious, you might not be sleeping. So it really goes hand in hand. Personalized treatment for common and uncommon symptoms. My key takeaways from that is that there are uncommon perimenopausal symptoms like ear ringing or tinnitus, burning mouth. They may have some hormonal association, but really make sure that you're not missing red flags. Okay? Just like we shouldn't be blowing off women's perimenopausal symptoms, we also can't chalk everything up to perimenopause and menopause either. We don't want to miss things. Hormone therapy can be considered if other menopausal symptoms are present. Trial and error, right? We can try it. If it works, okay. Structured choice, options, decisions. Make sure that you communicate and clarify risks, and make sure that you're guiding to the next steps as well. And then talk about realistic expectations, especially in perimenopause. And sometimes, hormone therapy isn't going to manage all the symptoms because of how that works. And talking about the contraception needs of perimenopause. Contraception, you guys, is still needed until menopause is confirmed. If you don't want to have a baby and you have sperm in your life, you need contraception. Okay. Natural fertility in some women can persist until they're 50. There are progestin only and non-hormonal methods, especially women for over the age of 50. If women are on birth control pills and they're doing really, really well, as long as their benefits outweigh their risks, they can ride that through until the average age of menopause. Again, maintain ongoing contraception access and counseling throughout the perimenopause to prevent unintended pregnancy and optimize transition to menopausal hormone therapy. So super important, continuous contraception that can improve bleeding control. Again, individualized care. You really need to evaluate the cardiovascular risk, their smoking, any medication interactions, cardiovascular risk. Okay. And then a really nice, misinformation lecture about, the term bioidentical is created for marketing. This is not a medical term. You've all heard us talk about that. We kind of incorporate that because a lot of our audience that's the verbiage that they're using. Natural doesn't always equal safer, right? Well, that's just a big takeaway there. We have to be careful with compounded formulations. You want to make sure that you are using a vetted compounding pharmacy when needed. Be careful with supplements and where you're getting them from. You really want to make sure that they're, again, coming from a place where it's clean and vetted, and you should prioritize third-party testing. Okay, day 2, longevity, metabolism, and the midlife reset. So if day 1 was the brain, perimenopause, day 2 was about the body and the, future of women's longevity. So, I really took here that the message echoed through like every planary. Aging is the number one risk factor for chronic disease, but it's also the most modifiable, meaning the goal just isn't to extend lifespan, but it's to extend health span, right? So I talk about this all the time with my patients. Like, you may want, it's great to live longer, but you want to be the healthiest you can be as you're living longer. So the years spent in good health, right? We looked at how ovarian aging drives systemic aging. The ovary doesn't just produce hormones. It's really interesting. It's a signaling organ that influences the brain, bone, muscle, and metabolism. So when ovarian function declines, inflammation, oxidative stress, and mitochondrial changes seem to accelerate. And all of these things then can affect cognition, heart health, and even cognition. Interesting, they're mapping how neuropeptides in the brain regulate energy, balance, appetite, and behavior. These all connect hot flashes, mood, and metabolism. So this is longevity science through a women's health lens. So let me back up and talk about how kind of like these key takeaways again. So in reframing longevity and extending health span, we prioritize health span over lifespan, right? Aging biology drives most chronic diseases. The brain ovary axis is central to a woman's aging, and ovarian aging links to metabolic risk variability. Early dysfunctional detection matters. So it's really interesting. There's cutting edge single cell spatial omics, I know, in ovarian tissue mapping how aging unfolds. Was really fascinating talk. Then we went into body composition changes in menopause, how menopause shifts body composition toward higher visceral fat and lower lean mass, raising mortality risk. Again, sleep was, a big key takeaway, an underlying message, I think, through all the sessions. Sleep quality and timing, strongly shapes adiposity, insulin resistance, and diet choices. Again, going back to the Mediterranean style eating, regular meal timing, and even small sleep extensions can improve metabolic markers. I want to go back and touch a little bit on that ovarian spatialomics. So interesting. In that lecture, they talked about how they mapped over 600,000 gene expression sites in the follicles and ovarian tissues. Is that crazy? So it's like a literal atlas of how the ovary ages. I just thought it was like really fascinating looking at those pictures. So, really it's the kind of data that will shape personalized menopause care, I think, just really interesting stuff. So, all right, back to body composition. So we went through the Mediterranean style eating, regular meal timing, and small sleep extensions. And we know that high rates of poor sleep, we need to make sure that we're screening and retreating. We know that by part of aging, that muscle tends to decrease and that visceral fat increases. And so those changes are what change insulin resistance, and inflammation increases. And then that increases mortality. Again, we talked about a lot of sleep. Sleep was a major theme. Poor sleep isn't a symptom, it's a driver. Okay. Short, fragmented sleep increases fasting insulin, then visceral fat and blood glucose levels. So, especially post-menopausal women, like I discussed, even small improvements, an extra, 20 extra minutes of sleep per night can reduce sugar intake and improve metabolism. Meal timing, both to improve late night eating. You got to throw it out, guys. Don't eat late at night. It's directly linked to higher diastolic blood pressure and glucose spike. Okay. Making sure that your resistance training, prioritizing your protein, all of the things that you've heard me talk about before. It was nice to see that again being discussed up there. And then, making sure still that you are treating anxiety, looking for eating disorders. And then we went on to talk about, GLP-1 and GIP-based metabolic therapies, semaglutide, tirzepatide, and the next generation multi-agonists. So, these medications really are revolutionizing obesity and metabolic disease, with trials showing 12 to 24% weight loss and significant reduction in cardiovascular events. There was also post hoc analysis showing that women on menopausal hormone therapy respond even better to GLP-1s. I see this clinically. So estrogen appears to have a synergistic effect, on weight and weight waste reduction. Then we went on to perimenopause and bone. Really great bone lecture. I was super excited because I don't know about you guys, but bone can be a little confusing. Not what happens and the pathophysiology of it, but just some of the other, treatments and do I treat and prevent and all of that. And so it's difficult for me to keep that in my brain. But perimenopause is a critical window for bone preservation. Half of spinal bone loss occurs before the final menstrual period. We know estrogen therapy in early menopause reduces fracture risk by up to 40%, with an excellent safety profile for women under the age of 60. And once estrogen is stopped, transition to bisphosphonate maintains those gains. So today's 2 theme, longevity isn't just green juice and supplements. It's understanding how estrogen, metabolism, muscle, sleep, and nutrition all intersect to determine how well you age. All right, let's move on to day 3, the heart, the data, and the disparities. So day 3 was all about the heart, and it was pretty powerful. It was really a lot of information, you guys. And I'm family medicine trained. So the heart and blood pressure is kind of like our bread and butter. And it was still a lot of information, even for me. So I was just like, oh my gosh, some of these younger kiddos, it was like drinking from a fire hydrant a little bit. So, they opened with a hard truth that heart disease is still the number 1 killer of women. All right. It still is the number 1 killer of women. And awareness is declining. Fewer than 25% of women with hypertension have it under control. And risk begins earlier. Women develop cardiovascular disease at lower blood pressure and cholesterol thresholds than men, but our guidelines still treat us the same. So midlife is an inflection point. As estrogen declines, we see rises in blood pressure, insulin resistance, and LDL. So this is like the perfect setup for, your first cardiovascular event, but it can be preventable. So key takeaways here: reproductive history is also cardiovascular history. Complications like preeclampsia, gestational diabetes, or infertility can increase future heart disease risk. Sleep is a cardiovascular vital sign. So less than 7 hours or fragmented sleep increases hypertension and metabolic risk. Social determinants, education, access, bias also play a major role in outcomes. We also talked about statins, that statins are equally effective for women and men, a 19% event reduction across 53 trials. Lipoprotein a, or LPA, is an under-recognized genetic risk factor. It should be checked at least once in a woman with a family history of early heart disease. SGLT2 inhibitors and GLP-1 agonists reduce heart failure and cardiovascular death in women by double digits. And blood pressure targets should be lower for women. Risk starts rising around 115/75. So then came one of my other favorite sessions, the microvascular dysfunction in women. 2/3 of women with chest pain but no blockages actually have small vessel disease. Isn't it crazy? It's neurovascular. It's tied to overactivation of the sympathetic nervous system, stress, and inflammation. So when these women undergo stress testing, their heart rate and blood pressure spike higher, and their emotional recovery takes longer. So this is where mental health meets cardiology. So the takeaway here for me was that heart disease in women looks different, feels different, and needs to be treated differently. And for the midlife woman, prevention is power. So move your body, track your sleep, know your numbers, and advocate for yourself because your heart is listening. And listen, we have to make sure that we're also catching those women with white coat hypertension. They need to be sent home with an ambulatory blood pressure monitor. All right, on to day 4. Hormones, non-hormones, and the future of midlife medicine. Day 4 was everything: the clinical pearls, the controversy, the innovation. And it started with swapping and stopping hormone therapy. 80% of women experience vasomotor symptoms. You've heard me talk about this. We've seen those numbers. 40% have them severely, yet most go untreated because of outdated fears and misinformation. The reminder here is that menopausal hormone therapy remains the gold standard, and it is endorsed by every major society for hot flashes, night sweats, the genital urinary syndrome, menopause, bone protection, and premature ovarian insufficiency. And no other therapy matches its efficacy. So, the lecture would walk us through practical pearls. You start with an effective dose and can personalize as well. I like to start low and go up. I just feel like if you scare a woman too quickly, they're not going to go back on it. So transdermal estradiol is preferred for women with metabolic or clot risk, that there is no age cutoff. Continuation beyond 60 to 65 can be appropriate if the benefits outweigh the risk. And we talk about this all the time when I'm treating patients and when you hear me on social. What about tapering versus abrupt stop? Again, individualized. 50 to 90% of women will have symptom recurrence after stopping. The next lecture was non-hormonal pharmacologic options. So SSRIs, SNRIs, things like venlafaxine, paroxetine. First line for women who can't use estrogen or don't want to use it. Gabapentin for nocturnal hot flashes and sleep, or nighttime hot flashes and sleep. oxybutynin for excessive sweating. But remember, they all also have side effects. So make sure that you're talking to your patients about this. Veozah or fezolinetant. This is the first NK3 receptor antagonist approved in 2023, which targets the KNDy neurons that are driving hot flashes. And it works within weeks and again is non-hormonal. You do have to make sure that you're following liver function. And during the Menopause Society meeting, the new drug that was FDA approved, the elinzanetant, was approved by the FDA during the Menopause Society meeting. Interesting, I was talking with one of the reps 2 weeks before that, and she was hoping that was going to happen. So the mechanism for this is non-hormonal. It's a neurokinin receptor antagonist blocking both neurokinin 1 and NK3 receptors. So they address the hypothalamic thermostat dysregulation. It differs from fezolinetant because that blocks only NK3, whereas elinzanetant blocks NK3 and NK1, potentially broader symptom relief, including sleep improvement and fewer liver warnings. So still need to make sure that you're watching it, however. So it just gives us another non-hormonal tool for women who can't or do not want to take hormone therapy. So as a specialist, you'll want to make sure that you understand the prescribing criteria of all of these and the monitoring that needs to occur with some of them. Some other non-hormonal CBD reduces hot flash distress, improves coping even when frequency doesn't drop. Clinical hypnosis decreases both subjective and physiological hot flashes with lasting benefits, and weight loss of even 5 kilos reduces hot flashes by 30%. Stellate ganglion block, a procedure for refractory cases, can provide relief for up to 6 months. Of course, the things that don't work, most supplements, acupuncture, and random menopause wellness trends. So data first, marketing second. Testosterone is approved with guidelines at 1/10 the male dose. So it's nice to have just a nuanced conversation about overall health, metabolism, sexual function, and brain. So, walking out of that conference, you're exhausted, you're excited, there's hope. It's not easy work. It's travel days. It's missed family dinners. It's late night catch-ups on charts, but it's also connection. It was so nice to meet a group of wonderful new women, to reconnect with colleagues and friends, to share with my daughter and her best friend this part of women's health. It reminds you that you're a part of something bigger, that women's health is finally being seen through a longevity lens. We're talking about brain, aging, muscle preservation, metabolic precision, emotional resilience, not just menopause symptoms. We're redefining what it means to thrive through midlife. So here's my message to every woman listening. You deserve care that's informed, it's individualized, and grounded in evidence, not fear. And to every clinician and founder, keep learning, keep showing up, and keep pushing the field forward, because this is how we change the narrative. This is how we build a world where thriving in midlife isn't the exception, it's the standard. So if this episode gave you a glimpse of what's possible when women stop waiting for the system to catch up, hit subscribe on YouTube or wherever you listen so you never miss an episode of the Founder Series. Subscribe on Apple Podcast, YouTube, and Spotify, wherever you like to listen to your podcasts. Rate and review the show. That's how other women find the science and sanity in midlife. And if you're ready to build your own longevity plan, you can visit osteopathicmidlifehealth.com to book a consultation or a free phone call, and we'll discuss your hormones, muscles, bones, metabolism, and design a plan to extend not just your lifespan, but your health span. If you're a clinician, you can listen to this on the Pinnacle app for CME. While you're there, you can also sign up for my newsletter, your weekly dose of clarity and science and sanity for real women in real life. So share this episode with someone who needs a reminder that thriving in midlife isn't luck, it's leadership. I'm Dr. Rebbecca Hertel, and this has been the Founders Series.